I'm very pleased to talk about this trial data. Actually, this is a trial, the collaboration study between the Korean breast cancer study group and the Japanese breast cancer research group. It's named CREATE-X. And this is a very brief background of this trial. The standard regimens of neoadjuvant chemotherapy contain the anthracycline and taxane. I think it's not changed very much. And the patient with pathological residual invasive disease after neoadjuvant chemotherapy NAC have higher risk for relapse. In general, particularly for estrogen receptor negative cases. It is unclear whether postoperative systemic chemotherapy following NAC is able to prolong the survival or not. This trial was designed as a multi-center open-label randomized phase 3 trial evaluating the efficacy of adjuvant capecitabine use for patients having the residual invasive disease, which means non-pathological complete response or not negative or not positive after NAC. This is a very brief sketch of the trial design to CREATE-X. The HER2 negative primary breast cancer patient, starting with neoadjuvant chemotherapy and surgery, and if pathological, the diagnosis said non-PCR or not positive, which is able to be enrolled in this trial and randomized to a control. That means the standard treatment. If hormone receptor positive, hormonal treatment should be considered. And the comparison, the standard treatment plus capecitabine, which is the trial arm, capecitabine arm, and obviously the hormone receptor negative, no further systemic treatment. And the stratification factors were estrogen receptor positive, negative, age, more than 50 or less than 50, the neoadjuvant chemotherapy, anthracycline and taxane, or anthracycline containing ODTC. The pathological, the nodal status, the node negative, and the 1 to 3 nodes and the over 4 nodes, and the 5 if you containing or not in the regimens of neoadjuvant chemotherapy and the institution, those were stratification factors. And radiotherapy was given if they needed. That's the capecitabine treatment. The arm, 2,500 milligram per day, about the 2 weeks on, 1 week off, repeated every 3 weeks for 8 cycles. Because of a safety concern, we started with the 6th cycle of capecitabine treatment. Then we planned to have a safety interim analysis of the first 50 patients treated with 6th cycle capecitabine. According to this, the safety interim analysis, actually it was feasible. The IDMC recommended the extension of capecitabine treatment to 8 cycles. Endpoints, the primary endpoint, the disease-free survival. Secondary endpoints, overall survival, in the period from the first day of the preoperative chemotherapy to recurrence or death. Safety and cost effectiveness. Consult diagram and treatment, the trial progress. Actually, from 2007, February, 2012, July, 304 Korean patients and 606 Japanese patients were randomized into capecitabine arm and control arm, and actually equally. And not meeting inclusion criteria, patient withdrawal, no follow-up data, those patients were excluded from the full analysis set. And the capecitabine arm, actually the 440, control arm 445. Data cutoff was conducted at the end of the September 2015. In 2015, March, the end of March, the first pre-planned interim analysis was carried out at the point of the 2 years follow-up from the last patient enrollment. After that, the IDMC recommended that this study should be discontinued according to the protocol. That's the main result, primary endpoint, disease-free survival. Actually, 5 years disease-free survival, 74% for capecitabine arm, 67.7% for control arm, hazard ratio, 0.70, and the p-value was the 0.0054, which was smaller than the 0.0067. Because of that, the IDMC recommended to discontinue the trial. So the conclusion, after standard neoadjuvant chemotherapy containing anthracycline and/or taxanes, postoperative adjuvant use of capecitabine improved the disease-free survival significantly in HER2-negative primary breast cancer patients with pathologically proven the residual invasive disease. OS was significantly improved by capecitabine. Adjuvant therapy for non-PCR or node-positive patient after neoadjuvant chemotherapy as well. The balance of the benefit and the toxicity would favor use of the capecitabine in the post-neoadjuvant chemotherapy situation, but the prediction for the therapeutic, the benefit needs to be further investigated. The cost-effectiveness analysis will be carried out soon. I think that's